Good evening, respected chair, panelists, and attendees. It gives me immense pleasure on behalf of the Neuro Rehab subsection of the Indian Academy of Neurology and the Indian Federation of Neuro Rehabilitation to welcome you to the panel discussion on multiple sclerosis on the eve of World Multiple Sclerosis Day. We celebrate World MS Day on the 30th May of every year, a day we all come together, a day we express solidarity in the fight against MS, a day we use to spread awareness and augment the learning amongst the treating and the rehabilitating community. And in line with the theme for the World MS Day this year, diagnosis. Rightly so, after diagnosis, we require a multidisciplinary team to manage and rehabilitate patients with multiple sclerosis. And hence, we have a multidisciplinary panel of esteemed neurologists, physiotherapists, occupational therapists, cognitive psychologists, and speech and language pathologists, spearheaded by the rehab physician, Dr. Abhishek sir, and my mentor, Dr. Nirmal Surya sir. And it's an amazing job for me to moderate this session, and I sincerely thank you for the opportunity for that. And we will be looking forward in this panel discussion about the newer updates in rehabilitation of patients with multiple sclerosis. And for the World MS Day panel discussion, we shall proceed with the introduction of the chairs and panelists before I hand over to Dr. Abhishek sir. So first, let me introduce Dr. Nirmal Surya sir, a person in the rehab and in the neurology community who requires no introduction, but there has been several updates in the last month that requires update in the current forum. And to start with, he is a chairman of the Surya Neuro Center, Mumbai, and he is associate professor of Bombay Hospital Institute of Medical Sciences, Mumbai. And he's currently the Secretary General for World Federation of Neuro Rehabilitation. He's president of the Asia, Ocean, and Congress Society of Neuro Rehabilitation, president of the Indian Stroke Association, and past president of the Indian Academy of Neurology. And he's founder president of the Indian Federation of Neuro Rehabilitation, and many more prestigious awards to his name, as exemplified by Kenneth Wiste Jr., MD Patient Advocate of the Year Award by the American Academy of Neurology. Next, we have Dr. Abhishek Srivastava, sir, who heads the neuro rehabilitation as the director and Center for Rehabilitation in Kokilabend, Dhirubhai Ambani Hospital, Mumbai. He is the chair of the neuro rehab subsection of the Indian Academy of Neurology. He is secretary of the Indian Federation of Neuro Rehabilitation, and he is chair of the special interest group multiple sclerosis of the World Federation of Neuro Rehabilitation. He is also WHO fellow for TBA rehab guidelines. He was the organizing secretary of WCNR 2018 and an IAPMR gold medalist, and several other prestigious awards to his name. Next, to introduce the panelists, can we go to the next slide, ma'am? I myself am the moderator. I'm Dr. Guhan Ramamurthy. Next slide, ma'am. And in the panelist, we have an esteemed neurologist who is the professor in the Department of Neurology at the National Institute of Mental Health and Neurosciences, Dr. Netravati, ma'am. We welcome you, ma'am. And ma'am's area of interest is demyelinating disorders, neuroinfections, adrenoleukodystrophy, HIV-related neurological disorders. She has several scientific publications in various journals and crossing over 102 publications with 15 book chapters in addition to that. And she is part of the National MS Task Force, co-principal investigator for the National MS Registry, and founding member of the MDSI, and several other achievements to her name. And next we have in our panel, Dr. Jwala Narayanan, who's a cognitive neuropsychologist from Manipal Hospital, Bangalore. And she has several achievements. Burning Man funded a community project to spread awareness on managing and preventing dementia 2019. Best Poster Award, International Neuropsychology Fellowship Award, Travel Scholarship by Ratan Tata Foundation, and part scholarship towards tuition fee for MSc program. And she has several other skills, including rational emotive behavior therapy in her armamentarium of treatment. And next in our panel, we have Dr. G. Srinitya. She is superintendent and head of occupational therapy, Department of Neurological Rehabilitation, NIMHANS, with 20 years of work experience as an occupational therapist in NIMANS till date. She has expertise in improving patient outcomes through individualized care plans, and she is panel and medical board member for patients with specific learning disability. And she has developed snoozelen therapy for dementia patients and awarded as best volunteer occupational therapist in NIMANS. Next, Dr. Hitav Someshwar, physiotherapist in our panel for today, and he is assistant professor, Early Intervention Center, TNMC and BYL Nair Charity Hospital. And his area of interest is acute stroke management, perceptual disorder rehabilitation, tele-rehab, and artificial intelligence. He has won the WFNR Travel Fellowship, and he is my co-mentee at the WFNR Mentorship Program under Dr. Nirmal Surya sir. And he is IAP Women's Cell Research Master Award 2022, IFNR Young Investigator Award, WFNR Masterclass member, and MUHS Avishkar winner 2016, and many more awards which he has not listed in this. We welcome you, Hitav sir. Next in our panel, we have speech and language pathologist, Dr. Preeti Shetty ma'am, and she is an assistant professor at Department of Audiology and Speech and Language Pathology, KMC, Mangalore. And she is treasurer and founding member, Society for Feeding and Swallowing Disorders, India, Dysphagia Core Group Council member, Indian Association for Parenteral and Enteral Nutrition, Task Force member of the Speech and Language Pathology and Audiology. She has several publications to her name. We welcome you, ma'am, to the panel. We welcome all the esteemed panelists on behalf of the chair and our subsection and the Neuro Rehabilitation Foundation. And with this, we first start our panel discussion with talk by Dr. Abhishek Srivastava sir. I hand over the podium to Dr. Abhishek sir to proceed further.
The slide is visible. Go on.
Yes, sir.
I'll have a little bit small talk on what are the changing rehab needs in persons with multiple sclerosis. With MS, as you all know, MS is a progressive disease. It's a third leading cause of disability in younger people. Women account for 70% of cases, and the cost of managing MS is substantial. One estimate says about $60,000 per year per patient, per person with MS. Also, people live near normal lifespan. They don't die early because of MS. The average is 10 years less in men and women, that's all. After about 15 years of diagnosis, 50% of patients use walking aids and 1/3 require a wheelchair. And first 10 years of the disease, more than half become unemployed. The younger people, disability, unemployment, lot of cost to the society per se. The management of 3 different types. First is the acute attack management with steroids and immunomodulation. Second, the underlying disease, primarily the use of disease-modifying drugs. A lot of drugs have come in the last few years. Neither will tell you about that in short in the questions. And third, today's focus is rehab and the management of symptoms in people with multiple sclerosis. So how do we classify multiple sclerosis? There are 4 different stages. Simple score called as EDSS score. When a person has initial diagnosis, is independent, initial stage 0 to 1. When these patients are still independent from mobility, outdoor mobility, early stage of disability, EDSS score 2 to 4. Later stage with moderate disability, when they are able to manage independently with walking aids outdoors. Stage 4, advanced stage, when they can only indoor mobility with using a walker or wheelchair bound or bed bound, called as advanced stage with severe disability, score more than 7. So we'll see in short, at all these 4 different stages, how the rehab needs are different, how we can target the intervention at specific staging. Initial stage, people just have the diagnosis of MS. They don't know what MS is. The main question is, are these people of MS ready with the diagnosis or not? And at this stage, the information is considered an intervention similar to medical treatment with side effects. They should have enough information on disease. Younger people who have seen so much of fear of being diagnosed as MS. In the early stage, people have various relapses, which from they recover, or they have gradual disability setting in. The main concern at this stage is the fear of becoming disabled with MS. And coping with MS and maintaining relationships, big points in the early stages. So what are the rehab intervention in the early initial stage? People have gone into panic, go into shock and depression. At this stage, should have a liaison role with the physician and the nurse or someone who work with the physician, to especially a nurse who work with the physician to give them information at a personalized level. The way we treat MS at this stage will affect how will they cope with disease in future. Also, at this stage, in the initial stages, people have occasional relapses, but they recover well. We to provide continuity of supportive care, medical management, nutrition, exercise, training, fatigue should be addressed. The special program for education person with MS on 4 different concerns, the person concerns, target medical information, adjustment skills, and life planning. All 4 are important components. Education person with MS at this stage. People have weakness, and generally we all thought that MS cannot exercise. It was a wrong notion. Endurance is the most important component of exercise. You can start this training very early in the disease process. Always remember, heat can worsen symptoms. So use the air conditioning setup for that, or use upper cycle ergometers. When swimming, good exercise, use cold pools to exercise if possible. Fatigue, the most important symptom of MS, multifactorial, because of disease per se, because of the diagnosis, because of the medications, comorbid conditions like diabetes, comorbid conditions like sleep problem, depression, anxiety, all cause fatigue. It is a major factor in disability benefits. People generally have classic afternoon type of fatigue. Main approach diagnosis management is repeated exercise program, supplementation, pacing techniques, energy conservation working technique. Medication can be tried, carnitine, modafinil, aminopyridines, limited role, primarily energy conservation and pacing techniques. Also, psychosocial support, very important. Train them, teach them how to take forward, take care of them, organize your life, take a break, practice relaxation. Simple strategies will help to counter fatigue at this stage. In later stages, EDS is about, you can say, 5 to 7. People have permanent impairments now causing disabilities. The main purpose at this time is to maintain the functional independence by specific rehab programs. People have impairments in cognition, behavior, spasticity, neurogenic bladder, ataxia, vision, speech, solo sexual problems. They require a multidisciplinary team of concept with a trained team. And today we have a whole team available with us, with neurologists, rehab physicians, physical therapists, occupational therapists, speech pathologists, psychologists, orthotists, all work together to help our patient at this stage. The key themes at this stage are multidisciplinary care to treat each symptom and disability management, to coordinate all these services, reduce the barriers to employment, education, and transportation, because if they can't go to work, they'll become unemployable. Also focus on alternative vocational rehab to keep them employable as much as possible. Okay, simple ICF model-based approach, they have multiple problems, cognition, speech, solomotor, bladder bowel. You treat all these things together in a comprehensive way. Strategies for focusing all these different components, a simple way to treat these people at this stage. In the advanced stage, they have severe disability. People are able to walk with walker in house, or they have become bedbound on the wheelchair or bedbound stage. How can you manage them? Where should you manage them? Staying at home, the best. If not, the nursing homes are required. You need a lot of environmental control units to improve the level of care they can get. Even at this stage, people can have multiple involvement. They can have bed sparsity, can have bed contractures. Some people require intrathecal pumps at this stage. Some patient with multiple disabilities, a new infection will require an inpatient rehab to be able to maintain the level of mobility they have indoor, outdoor stage. The key theme at this stage is to provide long-term care facilities, expertise in managing these patients with severe disability, utilize community resources, and then provide appropriate palliative care to reduce symptom management at this stage. Don't forget quality of life. People with MS, even from the stage of diagnosis to the end, have poor quality of life, and even the caregivers who are managing them also have a lot of burden on themselves. Don't forget the carers also help them with some time off the disease process and management. Very important term called charlatanism. People with MS have tried all different type of treatment, including snake venom, bee pollen, and whatnot, which is actually quackery. So our job in rehab is to educate them that these treatment in order to help them. What they require is the medical treatment with integrated rehab, make them as independent as possible. So any MS service, if it's running anywhere, should provide these 9-10 things to establish diagnosis, provide education, decision making, relapse management, symptomatic treatment, rehab and physical activity, disease modifying drugs, counseling, vocational rehab, health promotion, treat other comorbidities. They can also have diabetes, hypertension, thyroid issues, depression, anxiety to manage them, and provide long-term respite and palliative care. Just to summarize, it's a progressive disease of younger adult. Most people live with a normal lifespan. Diminished neurological impairments and functionality will happen. So what they require is rehab to improve the functional level of improvement in the patients. How to give this care, the MDT approach. And remember, as the disease is a progressive disease, regular rehab evaluation is recommended as per stage to plan their further rehab process. Thank you very much. Just a small talk to sensitize you how with disease progression, the rehab goals will change. Now we have direct to Gohan to start the panel discussion. Thank you.
Thank you very much, sir, for the wonderful priming talk that sets up the perfect stage for the panel discussion. And it was a wonderful overview of how rehabilitation evolves as the patient walks through the disease over the years. And rightly so, our multidisciplinary panel is eagerly itching to go forward to answer my questions. Thank you, sir. So coming to the next part of our session today, we have the panel discussion. And in this panel discussion, we start with the basics of multiple sclerosis and then we take forward. We have 3 rounds of questions and 1 per panelist. And I kindly request the panelists to keep up to their time of about 3 to 4 minutes so that we can take all 3 rounds of questions and that will benefit our attendees. So going forward, as we have seen now, multiple sclerosis, demyelinating disorder that affects the central nervous system, presents with a multitude of symptoms. And though the disease-modifying therapy targets the underlying disease, the rehabilitation measure is based on not only the disease, but also the manifesting symptom. Hence, my question to Dr. Netravati, the neurologist in our panel, is what are the rehabilitation methods in multiple sclerosis? And can you kindly shed light on the symptom-based approach?
A very good evening, everyone. I think Dr. Abhishek very nicely set up about the need of rehabilitation and at each stage is what has to be done. So when we try to see any patient with multiple sclerosis, so basically we need to see what are the symptoms which are there.
Ma'am, I'm sorry to interrupt. If you can talk a bit louder, please, or if you can hold the microphone a little closer to your mouth, it will be really well audible.
Is it audible now?
Yes, better, ma'am.
Okay. I'm sorry for that. So basically, we need to assess what are the different symptoms which are there in the patient. For example, most of the time, especially when the progressive form is going to set up, it is the spasticity and the bladder management which is going to be an issue. So based on the spasticity, now we have, I think those things are going to be covered. about the gait training. And nowadays, the robotic gait training has come up. VR method used gait training. Especially, it is more found in Parkinson's, but it has also been employed in CP and few of the MS studies also. So those are the first things. And initially, at least we should try with baclofen and baclofen assisted pump if baclofen has not been evolved. Then coming to the other modalities, like if there is a bladder bubble involvement, the bladder assessment has to be done using the bio urodynamics and based on the urodynamic as to what is the type of bladder, because nowadays it is not just a common thing or very common to just name it as LMN or human bladder. We most of the time find that there is a mixed type, and they based on the urodynamic studies we'll be able to tailor make the medications which has to be given in these bladder management. Then coming to the cognitive therapy, I think mainly what I want to tell is, as Gohan already told, there are a lot of other people here who are actually based on different cognition, speech, dysphagia, gait, and what are there. So I think they will be covering most on the different modalities which specialization is there. But what we need to do is, like for example, if a patient comes with ataxia, so it is going to be more of a gait training, and if it's a spasticity, it is going to be more of initially medications and then baclofen pump and then maybe the VR assisted, especially with AI coming into the picture. So we need to assess what are the symptoms which are there and then give them the appropriate, a tailor-made approach so that they will be able to benefit more from the rehabilitation. Thank you.
Thank you very much, ma'am, especially for highlighting the importance of spasticity in bladder and bowel management centered in the rehabilitation of patients with progressive MS. And that's one thing to remember very importantly in patients while we manage these people with multiple sclerosis. And coming to the next part, that's exercise. Exercise is beneficial in life. And we have come to the point in medicine where even to say that exercise is beneficial, we require randomized control trials and meta-analysis and to establish this fact, though we have known it for ages. My question to the master of exercise, that's Dr. Hitav Someshwar, sir, the physiotherapist in our panel is, what are some of the effective long-term strategies for managing the physical challenges of multiple sclerosis through physiotherapy? Further, it becomes very difficult to keep a patient motivated in the pursuit of recovery through rehabilitation. Hence, how do you ensure that patients remain motivated and engaged with their exercise regimens over time?
Thank you everyone for having me here, the Indian Federation of Neuro Rehabilitation, Dr. Abhishek, Dr. Nirmal. Dr. Surya has just joined in, so if you would just like to have him say a few words. Sir, would you like to say something before I can answer this question, sir?
Thank you very much. Can you hear me?
Yes, sir.
Okay. I'm at airport at Calgary. Was in second, I think, earlier, but as we all know that multiple sclerosis is a very, very important disorder. And it is very important to create a awareness and talk about beyond the limits. We must implement Johan and Abhishek to take this lead to get this panel discussion going on. And this is very, very useful for us, not only for the multidisciplinary team, but also for the people who are suffering with I'm sure the panelists would give you insight into how you can have more benefit inside your medicine and how you can help in the doctor. That's the best of your life. Thank you. Thank you very much.
Thank you, sir. So coming to the question that Dr. Guhan asked me, long-term strategies, because we've known through Abhishek sir's lecture and through literature that it's a progressive neuro disorder, which involves the nerves, the muscles, the brain, and everything. So the patient majorly spends time with us from his acute stage where he's diagnosed till his end of life care also that we generally take care of. So we generally have our sessions divided into three ones, and our goals are also divided into them. Is one is restoring, the other is compensating, and the third one is preventing. So in the earlier stages, in the acute stages, we work more on restorative therapy, followed by giving more. And all in all the phases, we always take into consideration preventive therapy, and then in the later stages, once the disease has progressed into the chronic stage, we always work more towards the compensation things. So the patient needs to be compliant to our therapies. So for the effective long-term strategies, it is always necessary to have personalized exercise programs for them. It can have a mix of aerobic exercises, strength training, flexibility exercises, and balance training. We always prefer to give them a new set of exercise every time they are there, although we are taking care of the same muscle or the same movement, but in a different way for them. Regularly, as regular assessments with the multidisciplinary team members is utmost important. Always we believe in giving them functional training so they can understand, and the brain also recognizes function rather than movement, as we've known. The other thing to keep them engrossed in therapy and to keep them compliant to therapy is giving them hydrotherapy, because aquatic based therapy is always fun and easy for them to take into consideration. And the most important thing that we do is education and teach them self management. I wouldn't want the patient to be dependent on a physiotherapy or any multidisciplinary team member. We would have them do that at home, and regularly visit us as and when the symptoms go up and down. Coming to ensuring that whether there is motivation and engagement for the patient, so again, have goal settings, make clear goals, smart goals, and have small victories for the patient once they achieve their goals or they maintain at their level. Have variety in exercises, as I have already told. Give different forms of exercises because they do get bored. They are adults who get bored in just doing the same form of exercises for the rest of their life. Have support groups like the MSSI, the Multiple Sclerosis Society of India, is doing a wonderful job. The Mumbai chapter is also very active. So they get to meet and greet different patients of MS. That helps in motivating them and get them better as well, because that has proven to be a powerful tool for them, providing regular feedbacks to them by the multidisciplinary team and mainly their neurologist and their physiatrist. Involving the family in decision making, in goal setting, as well as in rehab, family led rehabilitation. We've been discussing this a lot at the World Congress and through various literatures as well. Providing mental health support also, because that is sadly one of the least important things which we in our society are doing it, but more and more awareness need to be created, and providing them with professional support is the utmost important thing for them to be engaging in therapy and to be compliant to long-term therapy. Thank you.
Thank you, sir, for the wonderfully crafted answer, especially more so extrapolating this beyond MS as well. The important concepts of rehabilitation that is now transforming this field is that focus more on restoration early in the part, and when restoration is not happening, then later parts try to compensate. And always throughout the course of rehabilitation, try and look for any complications in earlier and try to prevent those complications before they actually occur. And thank you for highlighting this core concept of rehabilitation, sir. And to keep them motivated, that was an amazing answer, sir. Find different types of exercises even for the same muscle, because doing the same thing might get you bored. So coming to the next part of the panel discussion, that is whatever we say and do, considering the various advances in diagnosis and management in multiple sclerosis, boils down to the fact that are we improving the quality of life of the person with multiple sclerosis? Hence, my question to the master of the activities of daily living, the occupational therapist in our panel, Dr. Srinitya. How does occupational therapy improve the quality of life for individuals with multiple sclerosis? Ma'am, your mic is muted, ma'am.
Are you able to hear?
A little louder, ma'am, if possible.
Yeah. Good evening, everyone. Good evening, all the panel members. Good evening, Abhishek, sir, my all-time favorite person. And yeah, answering to your question, as an occupational therapist, there's one particular approach what we try to use. That is, there is no one-size-fit-for-all approach, which is applicable mainly for this multiple sclerosis patient. Because with that being said, we would like to concentrate and evaluate the capturing of the patient with that particular need. So always we go with something called POP model, where we concentrate or we focus on the people, the activity, and the environment. So when we focus on the person, what happens? Our strategies will be improving their self-management skills, apart from the physical functions, whatever the functional abilities being the prime core of our work. Apart from that, we also focus on their self-management skills, their activity performance, the problem-solving approaches in their day-to-day activities, and the coping strategies. When we talk about the activity performance, which optimizes the demands of the task and their habits and routines, what they follow every day, the routines, we structure them in a better way so that they are independent to the day-to-day affair. And we work on their environment, because that improves the quality much better in terms of the work adaptation or the home adaptation, the assistive devices that is required for each and every patient pertaining to aerial tasks, or we educate the caregivers about their fatigue management, what kind of problems that they would face day to day. Unless these things are known to people, it is very difficult for us to improve their quality. Why? What is the reason that we focus on person, activity, environment? Is our strategy is to restore the functional abilities, to adapt the process, include the compensatory strategies or remediation of losses, whatever has happened, and also to prevent the complications and whatever functional decline has happened to the patient. So our focus to improve the quality of the life of the person would be basically working on their on the self rather than other things. So our focus is for ADL, the adaptation, the person himself, the activities, and the environment. Yeah, that answers your question.
Thank you very much, ma'am. That's highlighting the importance of the PAE, people, the person, the activity, and the environment, and the interaction between the person and the environment, and how much it matters in rehabilitating the patients towards improving their activities of daily living. Thank you for the wonderful answer, ma'am. And now coming to the disability, that is the visible and the invisible disabilities, that is beyond the visible disability in multiple sclerosis, there are a multitude of invisible disabilities. One such is the cognitive deficit and the cognitive fatigue. So let us hear it from the cognitive psychologist, Dr. Jwala Narayanan. What is the role of neuropsychologist in multiple sclerosis, and does every MS patient need to see a neuropsychologist?
Firstly, thank you to the organizers for inviting me. It's fantastic to be part of this great panel today. I think, Dr. Abhishek has really set the evening well and, shown how interdisciplinary MS is as a condition itself. So I think in terms of neuropsychology, we sort of play an important role in terms of diagnosis and also with the rehabilitation. And I think, as we know, in MS, it can be so complex when it comes to sort of the psychology related issues. You have cognition, you have emotional disturbance, you have a breakdown in family matters. Sometimes you can have a one of the biggest changes, I think, is with identity. So I always see, MS as our role in MS as facilitating the patient or the person in their change in identity. So usually when someone has a brain injury, we're always sort of trying to bridge that gap between who they are and who they were and who they are. Whereas in MS, as it's a progressive condition that starts very young in their life, I always look at it as facilitating that change in their identity, the change in their aspirations of whom they thought they were. So what we really could do is really help them change that identity to from what they probably wanted to be and what they will be, keeping their values, their family's values, and really giving meaning and purpose in their life. So in terms of diagnosis, we do a lot of cognitive assessment. We try to understand how their brain is functioning, how their different aspects of cognitive functions are, including memory, attention, working memory, executive functioning. So to really assess and see where the patient is and if they can still continue to function at their current level. So if it's in a job, we always get questions from the company is asking, are they still able to work at the same capacity? So I think we play a very important role there. But of course, the medical fraternity, we're always assessing, reassessing, trying to see how they are, monitoring progress. Are they getting better after treatment, or are they the same? Are they getting worse? And in terms of rehab, I think we work with cognitive difficulties that they might have. There's a lot of cognitive retraining that we tend to do, also compensatory strategies where they're not able to retrain a particular cognitive ability. And of course, you can't do rehab without looking at a patient's emotional state. And we also play a role in helping them with pacing, managing their fatigue. So I think these are largely the areas that we work for with the individual patient. And I will also probably elaborate a little more with the families later, but we play quite a important role in mediating with the family, and a big part of, I think, our role is also in psychoeducation, and that really helps with the patients and the family.
Thank you very much for highlighting the importance of a cognitive psychologist in the management of patients with multiple sclerosis, ma'am. Next, we come to speech and language, and we understand the importance of language only if we are allowed to rehabilitate a patient with aphasia and motor deficit, and that's when we realize the importance of speech and language. And speech is such, it's the bridge between minds and is so important for communication. So it's important that patients with multiple sclerosis have good speech. And hence, to the speech and language pathologist in our panel, Dr. Preeti, what are the symptoms of multiple sclerosis that requires attention from a speech language pathologist and swallow specialist?
Thank you, Guhan, for that question. First of all, speech and language symptoms can widely vary depending on the location and severity of the lesion in the central nervous system. There are some of the symptoms which are common, which I would highlight here, is dysarthria, where they have difficulty in controlling the muscles of speech, leading to unclear or slurred speech, which is manifested in voice quality, articulation, and fluency. They may have dysphonia, where there is changes in voice quality because there is hoarseness, breathiness, and strained vocalization is there, which is due to the weakness and spasticity of the vocal cords that's there. There can be changes in prosody, which is alteration in rhythm, intonation, stress, and melody, which can affect the natural flow or emotional expression of communication. The other aspect that is important is dysphagia, difficulty to swallow, which can result in choking or coughing while eating or drinking, which can have the increased risk of aspiration pneumonia or nutritional deficiencies. They can have cognitive communication deficits, where difficulties in terms of attention, memory, processing speed, problem solving, word finding difficulties, all these are going to impact the communication effectiveness and efficacy. There's also going to be changes in language comprehension and production, which is important. And there are fatigue related speech and language difficulties that's going to be there, which is going to affect or make the communication more challenging as the day progresses. So I think it's very important to assess, diagnose, and provide a therapy which is going to manage all these symptoms for improving the quality of life for individuals with multiple sclerosis.
Thank you, ma'am. As multiple sclerosis lays its hands in all aspects of the neuro axis, and speech is no different from it. And thanks for highlighting the importance of multiple sclerosis affecting the articulation, the phonation, the prosody, the swallowing, and more importantly, the nutritional deficiencies that can add on and further worsen the neurological symptoms in these patients. And hence, it's important to bear in mind those patients with dysphagia, if they fit in with any of the nutritional deficiencies that worsen the symptoms of multiple sclerosis, and that's one to correct. Thank you very much to all panelists for completing the round one. And towards the end of round one, I request the viewpoints of the chair, Dr. Abhishek Srivastava sir, to add a few points.
I think two things come up. One is the concept of visible and invisible disability. As physicians, we primarily only want to focus on what is visible, and what is mostly missed. Most of the clinics, people come walking or coming with a stick. People see and send them back with a new prescription of medications. The message is, if the primary physician who's seeing this patient doesn't evaluate the invisible symptoms or cognitive problems, depression, anxiety, sleep, pain, sexuality, we don't see that, you don't refer to the proper team to take care of that, people will have a lot of problems. So we should identify these problems and utilize the multi-team approach to treat those problems. Second, what has come up is we all have seen so many impairments are happening in MS. Again, focus is on motor rehab. So always remember the invisible part. If you ask a patient, a person with MS, what is the most distressing symptom for you? He will not say mobility. He will say fatigue, weakness, bladder issues, continence, and sexual problems and quality of life. So always remember the invisible ones are also equally important. Until we ask leading question to look into it, it will be missed and they will suffer more. Thank you.
Thank you very much, sir. Next, a few viewpoints from Dr. Nirmal Surya, sir.
I think he's boarding a flight, not able to join.
Okay, sir.
He's come up. Oh, yes, come.
But I must say that I think that changed what it was 25 years ago. You won't think into it.
Sir, we can't hear you.
There are a lot of news that hello. Hello? No? Hello.
Hello.
Can you hear now?
Yeah.
Yes, sir.
Hello.
Yes, sir. Very
Clear
much, sir.
now.
So maybe my network is poor. So you'll have to. You can leave me.
Okay, fine. We'll go ahead, sir. Thank you.
So coming now to the next round of questions is now when we are treating and rehabilitating a patient with multiple sclerosis, the question that constantly keeps ringing in our mind, are we on the right track? And how do we know that? Let us ask our neurologist, Dr. Netravati, how to assess the improvement in patients with multiple sclerosis undergoing neurorehabilitation.
Thank you, Gohan. Why is it important to measure? Like, for example, we would have started medications for their MS symptoms in the form of when they come with the acute period. We start them with corticosteroids and then the disease modifying agents. So, what are the assessments we need to do? Because it is very easy to ask when they come back in the outpatient as to how are you feeling, what is the subjective improvement. They most of the time tell, I'm feeling very good, very nice after the injections. Then when you ask them what are the things which have improved, you will see that very few would have improved sometimes, or sometimes they may not have improved, or they may have remained static. So it is very important for us to assess which are the parameters which has improved and which are the parameters which have just remained static or worsened sometimes, so that we can take a appropriate management. For example, for a gait, in the busy OPD, it becomes very difficult. We may just ask them to go where a 2-minute walk test or a 6-minute walk test, which are there. But some places where there are a very good integrated centers, we may also have a wearable sensors with surface EMG. So with accelerometers. So those also will help us in trying to assess how good the gait has improved, because the goal, especially in gait management, is about increasing the lower limb and trunk strength and increasing the gait speed and endurance. So that is very, very important to assess. So just by asking them whether they're able to walk won't be enough. Then the other thing is about the quality of life. Quality of life, the MSQL is a very, very good questionnaire which is there. It just takes, when you take the whole thing, it takes for a longer period of time, but just the quality of life part takes less than 5 minutes to administer, but it at least gives you a clue as to how good they are. And it also will give you how much they are dependent on others, how much they are independent, and whether they also have a little bit of those invisible symptoms. So quality of life is one scale which has to be applied. Whatever I'm telling, this is going to be more of some research questions, or Of course, for a busy practitioner or a busy neurologist, it becomes difficult. But when you're going to refer them to your person who is going to rehabilitate them, they can do all these assessments so that you have a proper objective type of management. For example, in balance, you could have the Berg balance scale, which is there, and now that has been improvised by using mobile apps and video processed. And sometimes, even when it is just the hand which is involved, the 9-hole peg test definitely gives a better clue as to how it can be assessed. Then coming to the spasticity management, we know that most of the time we depend a lot on EDSS, but one thing with EDSS, especially with spasticity, is one thing that we may not be able to assess much, and sensitivity becomes very low. So Ashworth scale is one thing which definitely helps. And again, as I said, variable sensors with surface EMG. And I think already about dysphagia, Dr. Preeti already spoke about, and the bladder. The bladder, it becomes difficult, so we'll have to ask them about what are the activities of daily living they are going able to do independently and where they are going to be dependent. So charting out those definitely gives us an objective way of assessment. So among all this, sometimes it becomes difficult. For example, from head to toe, so many if disabilities are there, so at least two things: the quality of life and activities of daily living. So these two are the main things which we need to assess as to how much they are independent and dependent, and whether it has remained static. That definitely gives you a clue whether the medications or the therapy what has been given has been helpful or not. Thank you.
Thank you very much, ma'am, that for shedding light on disease-based outcome measures, symptom-based outcome measures, functional outcome measures, and finally the quality of life outcome measure. And these are the things that can help assess how the patient is progressing with the medical treatment, with the rehabilitation measure. And now an important but commonly neglected part of management of people with multiple sclerosis. An aspect to note for every practitioner is patient education. Let us hear it from Dr. Hitab. What role does patient education play in the physiotherapy management of multiple sclerosis? And beyond the clinics at home, what key self-management techniques do you teach your patient to help them maintain their mobility and function in their daily lives?
Thank you for that question, sir. Patient education has been a very dear topic to me. We've done enormous studies on it, and I understood that we're not good with patient education right from our bachelor days. We do improve over time, but we yet do not spend time. When I come from a government setup where we do not have time to spend with the patient itself, so how we go to patient educate? But why is patient education so important? Is because it empowers your patient with knowledge about their condition, and it equips them with the skills needed to manage their symptoms effectively. So what will patient education do is it will tell the patient what MS is in the layman terms or in the medical terms that is there. It will even enforce on the importance of exercise, even enforce on how to check for your symptoms, whether you're going into a relapse or whether you're having a recurrence or whether there is a progression of your disorder. It will help in preventing of the complications also, because we have patients who are lost to follow up in the long run. But once you have the charted down thing of patient education and the patients also noted down, made their nice notes, they would come back to you when they see certain complications that are in their earlier stages, like pressure sores or like some increase in the risk of falls, or some muscle going into wasting, or some postural deviation that are there. And again, patient has education helps in providing the patient with a holistic care. So it helps in addressing whether the patient needs to go to an occupational therapist, needs to go to a speech therapist, the neurologist, the physiatrist, everyone, all multidisciplinary professionals need to educate the patient regarding the condition, as well as the importance of their field as well, so that they're not lost to follow up. And coming to the second part of this thing is, once we've done with the patient education, what happens is the key self-management techniques that we tell them, where we tell them to do family-based rehabilitation or home-based therapies, where we have the patient record their videos And their exercises, they can be, you know, the aerobic exercise, again, the strength training, the flexibility exercises, as well as the balance training. We do even emphasize on the energy conservation part, because we've been hearing that fatigue, mental fatigue, physical fatigue is what is seen more commonly in our patients with MS. With the summer season here, our patients are drained. They are not up to the mark. They feel their symptoms have been exaggerated. They're going into a progression, or they're going into a relapse. So that's not there. That's the heat. That's the Uthos phenomena that we have generally seen. So energy conservation works with 4 Ps, that is planning, pacing, prioritizing, and positioning of themselves while they're doing those particular tasks. Telling them to, breaking the task into smaller things, taking adequate rest, prioritizing task. You can not wash a pack of clothes today, you can do it tomorrow if you're tired, but again, you need to do your exercises, stretch, relax, meditate, and then go ahead and do that. So prioritize your task, because sometimes, if they have to go out to for a social gathering, they are all exhausted. So we tell them what exercises need to be done in case if you have to go out, while they are prioritizing their task, because social integration is utmost important. That helps in improving the quality of life as well. Again, using warm baths is not necessary for them. We even tell them how to monitor and manage their symptoms. Right now, we are using ice packs and ice garments and weighted garments for our patients. So we even tell them how to use that in their day-to-day practice. Again, we have something called as assistive devices that we tell them to use for communication, that Dr. Preeti will also be telling you, and Srinitya madam will also be telling you. And home modification is of utmost important for them to prevent falls, because we have seen patients become bad or are deteriorating because of history of falls, because balance issues are common, muscle weakness is common, so there are recurrence of falls. So home modifications will help them in preventing that, as well as energy conservation occurs when your house is in a proper modified way, so that the task gets easier for you to do. And stress reduction again is very important. Diet and nutrition also plays an important role, so we do emphasize on these points to them. And the most important point and the last point is self advocacy. We need to empower our patients to take an active role in their care. Ask a lot of questions, get your answers, and communicate effectively, because if there is proper communication, they are going to understand what is wrong with them and how can they get things better, and they can take a charge for their betterment and their rehabilitation. Thank you.
Thank you very much, for especially if there is any young practitioner out there, it's a point to be taken. That is patient education, without which it would become very hard to carry on with the treatment, and all the more focus on diet and nutrition as well. These are some commonly neglected areas, and not only multiple sclerosis, but other neurological diseases as well. And it's a point to note. And thank you very much for highlighting these important points, sir.
Thank you.
Now, as fatigue embraces the person with multiple sclerosis, it affects all domains: cognitive fatigue, physical fatigue, sexual fatigue, and the energy reserve for the day ends earlier for a person with multiple sclerosis. And hence, let us ask Dr. Srinitya, what are some specific strategies you use to manage fatigue in patients with multiple sclerosis? Can you please unmute your mic?
So when we talk about the energy conservation fatigue strategies, so the first and foremost thing that comes to our mind is energy conservation techniques, where the physiotherapist was talking about prioritizing the task. I would also say, support his saying and say that yes, first thing in fatigue management would be prioritizing a task. The 6 P's that we just teach the patients about prioritizing, about planning the task. We teach them the positioning, different kind of positioning, what makes their energy level where they can maintain the energy level, the positive attitude. Instead of concentrating on what they cannot do and to waste their energy, they can focus on what they can do and work on it. And the first the breathing methods, whatever is there. So these are the main techniques that we work on the energy part. And apart from this, we also ask them to start the day with the higher energy, and as the days goes by, they follow the low energy patterns and avoid unnecessary energy draining during the activities. We see to that they don't do that. and the adaptive and assistive devices, whatever is necessary. For example, the ergonomic part, like for a lady to work in the kitchen or to at least do minimal activities, what kind of assistive devices can help her? For example, the electric jar openers or the lightweight utensils or the long handled, the reaches where she can pick out the objects, or the ergonomic stool where she can place one of the foot instead of long standing activities. So these kind of assistive devices can be prescribed for these people, and what we do also. And apart from this, we do something called work simplification strategies. So the task simplification from the simple task to complex tasks, we grade them. And also we use something called delegation method, where if they're not able to do the activity, how they can take the help of the others whenever somebody is there to help them around, use them for the activities. And as you said, as part of the cognitive fatigue, we work on their mental breaks, give them mental breaks in between, use activities with a lot of memory aids. We practice mindfulness, and also patient education, what he was talking about, is very, very important, because as a part of the disease process, first of all, they should be educated about why that fatigue happens and why that fatigue is there throughout the disease process, how they have to do their self monitoring for this fatigue, or how they have to maintain a diary and find out what is the triggering factor that causes the fatigue, so that they don't do, identify the pattern of fatigue, how they are able starting the day, or how it happens that they're not able to perform the activity, so that it will be easier for them to do anything very easily, and without any depression that they're not able to do the activity, or they go into a kind of thing that affects their aerial activities, main importantly, where even the basic aerial becomes a harder task for them to do. So these are the techniques that we try and give and educate the patient about the energy conservation.
Thank you very much, ma'am. I thought even 4 Ps was a mouthful, and now we have 6 Ps to the energy conservation technique, and that's very important for a patient with multiple sclerosis to carry on with this day, and that's an important patient education part as well. And now coming to that, the diagnosis that every clinician that we dread to communicate with the patient is that after all these years of relapses and remissions, you have now entered the progressive stage, the secondary progressive multiple sclerosis, and it has a significant cognitive component to it as well. So let us now ask our cognitive psychologist, Dr. Jwala, is there any benefit in neuropsychological rehabilitation for patients with secondary progressive multiple sclerosis?
Yes, thank you. So I think, when we think about anything that's progressive in the brain, we usually sort of compare it to a dementia. So I just would like to firstly highlight that, secondary progressive MS is very different from a dementia. And the way it progresses is quite different. It doesn't look like a dementia. Also, a lot of the cognitive abilities, you might have certain types of cognitive abilities or certain physical abilities that are progressing, but all the other functions might still be all right. So that's one of the biggest differences between like a dementia and secondary progressive MS. And what we found is it is quite helpful to do cognitive rehab and other psychological rehabilitation as well for people with secondary progressive MS. What we usually focus is, I think it's also been the theme of today, is our therapy, our rehab has to be very tailored to the individual. So, we look at things like what is it that they're losing, what kind of difficulties they're having in their everyday life, how their role has changed in their family or in their daily activities, and how we can then try to make modifications to that and suggest changes. So one of the some of the areas we usually work in is, a lot of people with MS tend to lose their social connect, their socializing abilities. They lose their friends. So that's something that we try to, try and engage people with. Either try to sort of send them to groups, or also try and get them to connect with maybe one really good friend that they had in the past. because what we find is when they do start socializing, when they do start speaking to people, the function can actually improve. So a lot of the times, the deterioration that we're seeing is coming from inactivity. So it's, you don't use it, you lose it. So I think that's one of the biggest, I think, help that rehab can do, is just making sure that all the functions are being treated, are being looked at, and are being stimulated. So that's really important. So also in terms of, looking at what kind of activities they did and where you can get them to start engaging more meaningfully in life. So it might be something like helping out in some part of the cooking or some part of cleaning the house. Also looking at, I think, the other therapist has spoken about assistive devices. So looking at what else we can use, like Alexa or reminders on the phone when people have memory complaints. So trying to really see what you can use to assist in your environment so that you can have a good quality of life and still engage with the family, still engage with your everyday life. And I'd also just like to answer the question I missed answering the first time around, if every MS patient needs a cognitive screen or a neuropsychological consultation. So I think while most a lot of MS patients, not most, but a lot of MS patients might not have cognitive issues when you see them the first time, I think it's still good to refer them to a psychologist if you have to do a quick screen. I think one is we have a baseline for cognition, and second, also they build that rapport with the psychologist. So they know that this is one person they could go to for all the issues. We could also go over some of the psychoeducation. So I think there is some value in referring to a psychologist for a cognitive screen for all MS patients. Thank you.
Thank you, ma'am, for highlighting the importance of cognitive psychologist in a patient with a progressive multiple sclerosis, be it primary or secondary. And now coming to this next, the final question of our round 2, that is, in speech and swallowing problems has been disabling patient with multiple sclerosis. Now to the speech and language pathologist, Dr. Preeti. How early should speech and swallow intervention begin in person with multiple sclerosis?
When you look at how early it has to be, there are two things that we have to keep in mind. Probably at diagnosis, even if speech and swallowing symptoms are not there at the time of diagnosis, it's good to initiate the assessment so that we have a baseline, and we also get an opportunity to educate the person with MS that what are the symptoms or potential symptoms that we'll have to watch for. Ideally, it is also important to note what is the first symptom that is there. Whenever there is a symptom like change in clarity of speech, or there's change in fluency, if there is change in forming words or sounds, frequently coughing, or these are the symptoms that we highlighted priorly, or if anything is there, if you watch out for these symptoms, if it is there, it's important to initiate the assessment and intervention, because there are multiple benefits of it, because it's going to prevent the complication. For example, if they have dysphagia, we can reduce the complications of malnutrition, dehydration, and aspiration pneumonia. If you are able to help them early in intervention of speech and swallow function, you will be able to prevent further decline. You are also able to improve the quality of life by allowing them to eat safely and ability to communicate, enhancing all these. And also you'll be able to tailor make the strategies. That is important, because we get to personalize the strategies where we can adjust the progression of the disease. I think that is a highlight of early intervention for me.
Thank you very much, ma'am, for highlighting the importance of speech and swallowing pathologist early in the rehabilitation of patients with multiple sclerosis. Now, after having coming to the end of round 2, let's proceed with the next set of questions in the final round 3. And since we are short on time, I kindly request the panelists to keep the answers to 3 to 4 minutes. And now coming to the field of MS, and it's one field which has witnessed transformations like never before. And so let us hear it from Dr. Netravati in the rehab realm. What are the emerging techniques in neurorehabilitation and multiple sclerosis?
Guhan, I'll keep it very simple. One is uh, medications are definitely have advanced a lot. Even when patients are going in towards progressive form, we should never give them physiotherapy or rehabilitation. Medications are definitely a must. I see many times when patients develop either wheelchair bound or start developing a lot of spasticity, they give up and they go for indigenous medications and they stop having any of our medications. So what I would want to emphasize is medications research have done so much that now there are very good medications. Of course, that has to be tailor made to what they have, and that has to be discussed with the neurologist and then started. That is the first thing. That is from the medical point of view. Coming from the rehab point of view, what you asked about the newer technologies which have come up, one is, I already mentioned few things. I'm just going to tell them. One is the VR headset or the head mounted displays which can be there, which actually helps, especially when they're trying to have a very good gait. This also gives a very good feedback, and it is a real time. It will also have a real time assessment and also gives as to how it can be improved, and operating motorized wheelchairs. So these are all very helpful, enhancing the spatial awareness. It also gives a lot of alternative to the traditional rehabilitation program which is there. I'm not going to more detail on this, but and the other thing is about the robotic gait training, robotic exoskeletons which have come up, which are actually helping a lot, especially when they are going to be used. Sometimes when we talk about all this, the fear is about the financial constraints. But what I want to tell is, initially when they are going to um put forth all this, it's going to be a little difficult. But when it's going to be done on a large scale in a big rehabilitation center, then it becomes more easier for patients to be using it and becomes less financial burden. And of course, a lot of computer assisted cognitive rehabilitation, I think that is very well known. Thank you.
Thank you for highlighting these emerging techniques and technological advances. And it just kindles my curiosity further because the technological advancements in rehabilitation has boggled the minds of many rehab specialists and inspired the minds of young students into rehabilitation. And it is these technological advancements are one small step for man, but one giant leap for a rehab fraternity. So let's explore this further from Dr. Hitav. How has recent technological advancements in physiotherapy, such as this virtual reality, which ma'am was mentioning, or telerehabilitation, that's your favorite and our favorite and our mentor's favorite, has impacted the treatment and management of multiple sclerosis? Are there any specific technologies you find very promising or beneficial for multiple sclerosis?
Yeah. Thank you, sir, for that question. And yes, as Netravati madam also said that not only medicine, but even rehabilitation, there have been enormous technological advancements that have been there, and we've been studying, we've been using it regularly in our patient. If you ask me, how does it impact our patient? There is increase in accessibility if telerehab is there or telemedicine is there. It increases the accessibility of our patient to reach our therapist as well as the doctors. There is immense engagement because who would like to just do exercises? But in a virtual environment, if you're say suppose on walking on Niagara Falls, that's more enthralling and more compelling for the patient to get rehabilitation, and that helps in increasing their motivation and enhancement. Plus, there are personalized therapies, as we are always discussing this. Jwala madam has also said that no one size fits all in rehabilitation. So you have to have personalized therapies. So these will help us in generating personalized therapies. My best bet is on artificial intelligence and machine learning to get it better. It helps in objectively monitoring them using wearable devices and using, distance monitoring for our patient. And again, it provides an holistic care and it gives them that reminder. There is a My MS app, if everyone can just go through that and see, it helps the patient in monitoring his medication use, his symptoms, as well as his exercises that can be used. And the most promising technology, if you ask me, it is going to be game-based rehabilitation in virtual reality using an artificial intelligent robot, or using artificial intelligence or machine learning is going to be a game changer. And specific to MS is going to be using cold compression. because we've been doing a study recently where cold compressions, we have these cold pads which are fitted in the patient's, the abdominal area and the upper thigh and the groin region. And, even on a hot day, they have had better results and, better productivity and better energy conservation through that. So these are the two things that is going to help in rehabilitation for our patients with MS. Thank you.
Thank you very much, sir, for kindling interest more in the cold therapy for patients with multiple sclerosis. And now coming to our occupational therapist, and from an occupational therapist point of view, how can occupational therapist support cognitive function in MS patients, and what interventions are most effective?
Yeah, when we talk about the cognitive function in MS patients, we know there are problems with the complex attention, slow processing the information, or problem in information processing, problem in executive functions, or long-term memory issues we tend to find. So we start with something like memory strategies where we use mnemonics and association method with different activities. The memory aids like calendars or the planners, like the psychologist was talking about the new now techniques with the mobiles where there are a lot of alarms, organization, and this reduces. We also teach a checklist to enhance organization and to reduce the cognitive load for the patient. And apart from the integrative therapies like music and art to improve their function. And one main thing what we all time use is the cognitive occupation-based program where we engage the patient in everyday occupation. That would be the basic thing where we use something called cognitive orientation to daily activities. This mainly is an approach where the therapist acts like a coach to the patient. And through this approach, what we do is we try to identify the solution for the motor problems. And then we improve their occupational performance, which is very important for day-to-day activities. And through this approach, our main focus as far as its cognitive function is the motor acquisition, the cognitive awareness, metacognition, and skill generation, which improves their cognitive functions of these multiple sclerosis patients.
Thank you, ma'am. And this question wouldn't be complete without a few points from Dr. Jwala. So, ma'am, would you like to add a few points to this question as well?
I think, there's a lot of sort of overlap with OT and neuropsychology and what we do, and sometimes speech therapy as well. But I think when we talk about cognition, I think the most important thing that we have to realize is you don't always have to do one particular activity for a cognitive function. So I think the more you can incorporate it in your daily activities, the better it is for you, because then it becomes more meaningful and then the person is motivated to do it more. So for something as simple as attention, rather than, just doing something like a grain sorting task or something like that, I would say try to, see what the patient is interested in. If the patient likes to read, then you say, okay, why don't you start reading for about 10 minutes? Or if someone likes to cook, or someone likes to maybe listen to a podcast, and you say, let's start with 10 minutes and then slowly increase that, and increasing the attention span like that. So I think just like that, if we look at all our cognitive functions and you look at all your daily activities, if you do everything, then there's a lot of cognitive stimulation that's happening. So I think that time we should sort of rely on something that's more specific to an exercise is when we're not able to get the person to do daily activities or any other meaningful activities. Then we try to, do some games, or we do certain exercises that improves cognitive function. So that's my take on cognitive retraining.
Thank you very much, ma'am. Now I have another question for you as well. Like, MS is impacted social and family life of the patient beyond the physical disability. And so what are the key features of MS that can interfere with family systems that needs to be communicated?
Yeah, I think, MS is something that can affect very young people. So sometimes it's people who have just gotten married, or people who are going to get married, or, much younger, or sometimes midlife. So, it's through the lifespan that someone can get a diagnosis of MS, usually younger. So it's really important to work with the family because there's a huge burden on the family and the roles tend to change. So, if someone is the breadwinner, then the spouse has to take on that role. If you're the primary caregiver to your children, then again, that role is going to change. So there's a huge burden and the family dynamics itself changes. So again, there, we need to sort of try and see how roles can be shared, what roles the patient can still continue to do, what the family needs to do. So I think they're having some expertise, really trying to share the roles, trying to split the work, really planning it for them can be very helpful. Also liaising between family members, explaining lots of psychoeducation to the rest of the family. So I usually bring in the children. Like I remember one of the children I got in, she was just 11 and she stared at me and she said, is my, mother going to die? And so it's really important to bring in the whole family, counsel all of them so that you have a happy family. If you have a happy family, you have a happy patient. If you have a happy patient, you have a happy family. So I think it works both ways. So it's very important to work with the family.
Thank you very much, ma'am, for highlighting the importance of working with the family in a patient who lives with multiple sclerosis. And now coming to the fag end of the round 3 and hence the fag end of the panel discussion. Now that we have seen the importance of speech and language pathologists, my question to Dr. Preeti, what interventional strategies can help patient with speech and swallowing issues in multiple sclerosis? Also, can you please highlight the prognosis of these interventions?
Yeah. Thank you. Basically, if you look at speech and language or swallowing intervention, some of them to highlight is articulation exercises where you're going to target the muscles, which is going to strengthen, which is important to strengthen, and they're involved in articulation. For example, if you have specific sounds, you can use the minimal pair drills or intelligibility drills. You can also have techniques to improve the breath support, such as diaphragmatic breathing or controlled inhalation or exhalation. You can have techniques that addresses the pitch control, loudness, and resonance. One of the evidence-based practice that we have is Lee Silverman voice treatment, that is LSVT loud, which is very, very effective in vocal loudness and clarity in neurological condition. We have assistive technologies which can range from simple picture boards to sophisticated speech generating devices which can be used or which can assist severe speech impaired patients. We can also have speech amplifiers where you can amplify the voice and allow them to communicate easily and help them improve the quality of life. You can have some of the behavioral strategies like pacing technique where you can slow down the rate of your speech and improve intelligibility. You can also train the communication partner so that you can reduce the background noise, have maintaining eye contact or using clear speech or concise language, which is going to be useful for the patient to communicate. If you look about swallowing intervention, there are several exercises that can strengthen the swallowing muscles. There are different manuals based on the symptoms and phase of swallow that is affected, and it will help improve the coordination of safety during swallowing. There is neuromuscular electrical stimulation, again, that's going to strengthen the muscles of swallowing and also going to improve the effectiveness of swallowing. And there is dietary modification that can be done for patients with swallowing issues by texture modification, where you can look at which consistency is a problem. Is it a liquid or a solid? And you look at how you can improve on these. It can be either pureeing the food, thickened liquids, or you can choose a softer solids which is useful for them. And also you can have positioning techniques which can facilitate the swallowing. I think these are the main factors that's going to be there, and depending on the severity and stage of the disorder, the prognosis is going to be, and if you start early, I'm definitely sure it's going to be benefiting for the patients with MS.
Thank you very much, ma'am, for highlighting the various speech interventions that can be helpful in this patient population. And now, after having come to the end of panel discussion, we do have some questions for the panelists. And with the permission of the chair, can I please take these questions? Thank you, sir. So the first question that has been posted is, what is the role of rehabilitation in late outcomes of latent MS?
Netra can take it, I believe.
I don't believe in latent MS because MS is one thing which is a progressive disorder. It can either start as an inflammatory phase and eventually become progressive, or it can remain at just that relapsing remitting phase. So when we mean latent, maybe I don't know whether I understood the question properly. So late outcome, maybe it is about the progressive form of MS, which the person must have asked. So what happens is, like, most of us have already discussed about different aspects about depending on what symptom is involved. I think the rehabilitation technique has to be tailored to it along with the appropriate disease modifying agent. So whether it is relapsing or progressive, medication is a must along with proper rehabilitation. I think that would be better. Thank you.
Okay, to summarize that, so we have a disease modifying therapy that helps target the multiple sclerosis. Then we have disease-based specific rehabilitation measures with regards to MS. It's going to be an energy conservation technique that has to be followed, not exhaust all the energy resources that we have in the process of rehabilitation, and top it up with all symptom-based rehabilitation measures, depending on what the symptom that the patient is going to have. If it's going to be a motor symptom, it's a weakness, then it's an endurance-based training. If it's going to be a spasticity, it's pharmacological and non-pharmacological measures and other interventions for spasticity. And other important symptom that happens in patients with multiple sclerosis is vision. If it's a visual acuity, then we try to restore it with the treatment. But if you are unable to restore, there are compensatory techniques available, like you can use a sensory substitution device. The commonly available app on the App Store is a voice app where it can be used by patients with the acuity deficits. And if it's going to be a field deficit, then we have the training of visual search therapy, visual restoration therapy. Then we have Prism usage for shifting the visual field. And these are symptom-based rehabilitation measures in multiple sclerosis. And that's the common ones are the vision and the motor. And again, bladder and bowel has been seen extensively through our panel discussion. So it's a disease-based therapy and the disease-based rehabilitation measure. On top of that, we have symptom-based, symptom-specific rehabilitation measure. And I hope that answers the question. And the second question that we have is that, again, to Dr. Netravati ma'am, is that if a young MS patient wants to marry, what suggestion would you give for this patient?
There is a myth that once you develop multiple sclerosis, that most of the time you will not be able to advance your career or advance your marriage. Yes, MS affects very young people, especially when they're about to get married or just got married or they are about to start family. What I would want to emphasize is, first, make if the diagnosis is confirmed that it is multiple sclerosis, so you'll have to have a proper conversation with your neurologist and see that your MS symptoms have become better. That is, some people, even last week I had an argument with a neurologist about this. But once you're diagnosed with MS, they feel that you should not give them any medication so that they have their family and then they should be giving medication, because you're giving a medication which is going to be an immunosuppressant. So that is a definitely no. What happens is, if you're going to delay the medication even by 6 months, 1 year, or 2 years, your progressive form of disease is definitely going to be more. So once you're diagnosed with MS, take the treatment which is required, keep it under balance for at least 6 months to 1 year, and then definitely you can plan your family. And the medication has to be discussed with the neurologist, because there are few medications which can be given, which some cannot be given. So that is the reason you need to have a discussion and then start your family. But yes, you should be starting your family.
Thank you, ma'am. And any words from the panelists regarding this question? Okay, with that, we have come to the end of the questions and the panel discussion, and we have had an extensive discussion from all the panelists today. And now I request our chair, for Dr. Abhishek sir for the viewpoints on our panel discussion today.
Very good panel discussion on all different components of MS care. Just to summarize a couple of points, that combination of medical management with integrated rehab is the way forward. You have to take a medication. Without that, you will worsen faster. Second, regular evaluation is recommended both by the neurology team and as the rehab team as the goals and symptoms changes with disease progression. Third, impairment-based approach, targeting on all different impairments of cognition, speech, language, behavior, bladder, bowel, sexual mobility, is the way to tackle it in a more comprehensive way with the help of multidisciplinary team. There should be adequate use of technology, which is coming up a big way. And last point, don't forget, people live longer, people live near normal life with MS, with a disability. So long-term palliative care and respite care services are also equally required in the end. Go on, back to you.
Thank you very much, sir, for the pearls of wisdom and the final golden words for the panel discussion on the eve of World MS Day. And we have had a wonderful panel discussion, and I hope it was enlightening and you had new points to all the attendees. And thank you for joining us today. And before we end our session today, I would like to place on records my sincere and heartfelt thanks to the Indian Federation of Neurorehabilitation, the President, Dr. Nirmal Surya sir, our mentor, and the Secretary of IFNR, Dr. Abhishek sir, the Neuro Rehab, the Indian Academy of Neurology, the President, Dr. Debashish sir, and the Secretary, Dr. U. Meenakshi Sundaram sir, and to all the esteemed panelists for taking time on this busy day amidst your clinic to join us for the panel discussion. Dr. Netravati, Dr. Hitav Someshwar, Dr. Jwala, Dr. Preeti, Dr. Srinitya, and thanks to all the attendees for joining us today and having benefit, and hope you all have benefited from this panel discussion.